Good morning, all. So, I'm Dr. Lokesh, Assistant Professor of Psychiatry. So, today we are gonna talk about anxiety disorders. Okay. So, in anxiety disorder, mainly we will be dealing the hormones or neurotransmitter which we are dealing with is dopamine, serotonin, and norepinephrine. Among that, as you see, the levels of norepinephrine will be increased in anxiety disorder. So that's a reason for any of your physical symptoms and cognitive symptoms in anxiety disorder. Okay. So next, just introduction, as all of you know, the commonest psychiatric disorder is anxiety. So most of the people will be having anxiety disorder at sort of in life. So anxiety is a normal phenomenon which is characterized by a state of apprehension or a unease arising out of a anticipation to a danger. Anticipation, they'll be anticipating the danger. Okay. So anxiety is often differentiated from fear. So fear is an apprehension to a external danger, while anxiety is a danger is largely unknown. So the what will be the danger is will be unknown, but fear is something different. Fear is to a particular thing which is endangering their life or which is very danger to their life. Okay. So then some anxiety is sometimes it comes through a trait actually through the habitual tendency to from the familial. Okay, then state anxiety is a cross sectional or due to any particular reasons. Okay, then symptoms consist of a motor. Okay, then autonomic and visual symptoms. Then cognitive. Then then psychological. So in first motor we will talk. In motor symptoms tremors, restlessness, muscle twitching, fearful facial expression. In autonomic and visceral symptoms, autonomic as autonomic systems increase. That is palpitation, tachycardia, sweating, flushes, dyspnea, and hyperventilation, constriction in the chest, then dry mouth, frequency and hesitation of a maturation, and dizziness, diarrhea, might. Most of us, most of we would have like what to say, have explained these things in certain situations like in by exams, in stage. So it depends on different type of anxiety. Okay. Then psychological symptoms. Psychological is your cognitive symptoms. That is poor concentration because if we keep on your concentration will be on some other like what to say the anxiety domain and distractibility, hyperarousal, vigilance or scanning. Then negative automatic thoughts. Then perceptual symptoms like derealization, depersonalization. Hmm? Then fatigue symptoms. This is one of the thing where the like what to say it where it affects the individual person's day-to-day activities, day-to-day lifestyle, everything. So affective symptoms are diffuse, unpleasant, vague sense of apprehension, fearfulness, and inability to relax and irritability, feeling of impending doom when severe. So impending doom is like a fear of dying, some sort of this world is going to end. So they'll be having a fear that when they're exposed to very severe sort of anxiety, either situation or a particular object or any environment situations, so they'll feel like something's going to bad happen. So bad going to happen to them. So they'll be having a fear of death. That is called impending doom. That is also one of the affective symptoms in anxiety. Then all of us like apprehension, fearfulness. So there'll be always apprehension about what will happen next, what will happen next. What if I some anxiety problem will come to me at a like a normal stage where if I am surrounded by some sort of or any close relatives or friends, suddenly the anxiety attack will peak. What will happen? What will happen? So that apprehension of unknown fear. Okay. Then insomnia. Initially, there will be insomnia, and especially the what to say in insomnia, there will be two things. One is sleep onset, that is why you're going to sleep, and sleep maintenance. So most probably in anxiety, they'll be having the insomnia. That will be the in the main thing in the initial phase. That is they can't able to go for a sleep. Okay, so they'll be having initiation difficulty in initiation in the sleep So initiation and sleep, that is a different. So why I'm telling this initiation maintenance is because it has a implement in the management part. So if there is initiation and sleep, so we'll be giving a different sort of benzodiazepines. If there is initiation, if there is any maintenance sleep disturbance, we'll be giving a different sort of benzodiazepines. Okay. Then increased sensitivity to noise, exaggerated startle response. So there always apprehension about everything that happen. So there'll be very minimal or very trivial sound that can increase sensitivity though. So and sudden startle response happen. Okay. Say for example, sudden any object falls or any small sound or noise that will that will start them very high. Okay. Then coming to types of anxiety disorder. Types, so these are the various types of anxiety disorder. One is generalized anxiety disorder, panic, phobic disorder, post-traumatic stress disorder, and obsessive compulsive disorder. So in this in this thing, after going into detail into the anxiety, these five categories we are going to see, and each five category we will be like touching all these five categories. Okay. Now, coming to a general pathophysiology, like GABA is a main system involving in the there are various neurotransmitters, right? GABA and I said like dopamine and so GABA is one of the main role playing in the anxiety disorder, like GA, generalized anxiety disorder, then panic disorder, then PTSD. So they have observed that there are various the receptors are various reduction of firing in the anxiety disorder. That is, one is GAD, reduced temporal lobe benzodiazepine receptors are observed in, especially in GAD. The benzodiazepine receptor should be proper, that is reduced in the temporal lobe especially. So if there is any altered benzodiazepine receptor in the temporal lobe, GAD is a patient developed GAD. Then PTSD. In PTSD, there is a cortical benzodiazepine receptor forming, the reduction. Then panic disorder, there will be a specific GABA type, that is GABA A. That binding is reduced in the panic disorder. Okay. Then coming to serotonin system, 5-HT. Serotonin is involved in the pathophysiology of anxiety disorder as an abnormal regulation of serotonin release and reuptake or abnormal response of 5-HT. Since there is an abnormal regulation of serotonin or reuptake mechanism, so we'll be giving the serotonergic agent like SSRI, like cycloserotonin reuptake inhibitor. So we will reduce the reuptake into the vesicles. That is a problem in the anxiety disorder. Okay. Locus cell is a part of the part that is located in the brainstem. And so in terms of any, say example, any threat. So the locus cell serves as an alarm center. So if patient exposed to any threat, then the alarm center will be the locus ceruleus. So then it will act as a center for release of norepinephrine. So as alarm triggers, that alarm is a triggering factor, triggering for release of the norepinephrine. That norepinephrine that leads to anxiety. Okay. Then other agents which can mimic like kind of anxieties, your carbon dioxide inhalation, caffeine. This can act in the pathway of anxiety that leads to the anxiety kind of symptoms. Okay, that release a norepinephrine into the bloodstream. That again leads to your anxiety sort of symptoms. Okay. Then coming to GAD, chronic anxiety disorder with the uncontrollable worry. Okay. This is a chronic anxiety state associated with uncontrollable worry. They will be always persistent, day to day, daily, from morning to night. They'll be having the GAD, the anxiety symptoms without reason, without a cause. This is the example like incidence and onset. Okay, then having persistent, excessive, unrealistic worry associated with muscle tension and impaired concentration and insomnia. So these all compile daily and troublesome to the patient. Okay, then complaints of shortness of breath, increased like kind of hyperventilation. So that leads to shortness of breath. Then palpitation and tachycardia are relative. Okay. Then alcohol abuse and depends on common GAD because once patient starts taking alcohol, or patient or anyone having anxiety take alcohol, so initially it will be a like relief for the patient, but later on it will be troublesome for the patient. So alcohol abuse is more common GAD patient, and we should counsel them regarding that. Okay. Then risk factors, as I said, it comes down to the family, increases the stress, exposure to physical, emotional trauma, unemployment, poverty, and drug abuse. Then, diagnosed when an individual experiences unrealistic or excessive anxiety for at least period of 6 months. So, period of 6 months is a criteria month or time period or criteria for the diagnosis of the anxiety. Okay, we should not label everyone who is having palpitation or breathlessness. We should not say them anxiety. They should fulfill all this criteria for 6 months at least. So, additionally, the patient with difficulty controlling anxiety and worry, accompanying the anxiety and worry for 6 months with three another following symptoms. That symptom is feeling tense or restless, easily fatigued, difficulty concentrating, irritability, and difficulty with sleep. Then panic disorder, characterized by discrete episode of acute anxiety. Okay, comes in next topic. That is characterized discrete episode of acute anxiety. Short anxiety period. Because it will be frequent in, I got to say, frequently it will happen, like 2 to 3 days once, or in a day, intraday, in a day, morning and evening. So it will be increasing. Then we have to give for treatment. Okay. Then may be or may not be an underlying generalized anxiety disorder. They can be or cannot be. So episode we should answer then sudden answer and last for a few minutes and few minutes to few minutes. Okay. Then classically the symptoms begin unexpectedly or out of the blue. Depends on the I was sitting calm, I was sitting relaxing in the class. Suddenly, out of nowhere, I got the anxiety. Suddenly, I had the fearfulness, palpitation. I couldn't able to appreciate why it happened. That is called unexpectedly, out of the blue. Okay. So those times, I mean, when it comes in the patient mind, sometimes something going on in the patient mind, something they will think of that any traumatic event they had in the past. Okay. Symptoms are again palpitation, sweating, trembling, or shaking. Here, the shortness of breath will be more in panic disorder and chest pain or discomfort. Chest pain is because of increased hyperventilation, increased chest rib, your what to say, respiratory muscles actions and the expansion of rib cage. So that's that time that leads to kind of feel of chest pain or discomfort in the chest. So that then people will have may have feel like oh something's going bad going to happen. They're going to die because of enemy or micro infection or something, angina or something. So they'll be having more fear. That fear leads to more anxiety. Okay. Then nausea, feeling dizzy. Because of shortness of breath, they'll be having feeling dizzy. Then fear of dying, as I said, impending doom. Then parastasis. Then chills or hot flashes. Okay. Then there are some differential diagnoses for anxiety. There is like hyperthyroidism, second to hypoglycemia, then pheochromocytoma, and third is like mitral valve prolapse syndrome. These suggest for organic part I added. Then diagnosis. As I said, it lasts kind of minutes. Okay, so peaks in 10 minutes and lasts no longer than 30 minutes. So it maximum 10 to 30 minutes it will happen. Okay, by diagnosed anxiety disorder, that individual have disorder for the 1 month or more, persistent concern over the future attacks. Okay, so there'll be always concern. Okay, what happened? What if I again develop this panic attack in the uh, next week or future, near future? So they'll be always having that thought in their mind. Okay, so as I said, they will feel like they were going to die because of panic attack. Okay. Then management for panic attacks, there's psychotherapy, relaxation therapy, benzodiazepines such as alprazolam, clonazepam. Or as I said, like we have to because the ABA receptors are involved, so we have to give alprazolam under clonazepam. There's a benzodiazepine. Or usually short-term anxiety, short-term treatment for both generalized and panic disorder. And beta blockers such as propranolol, atenolol are particularly useful in the management of anticipatory anxiety. Example, those like what come next? What if I develop anxiety after going that way? So anticipatory, expecting anxiety, not having anxiety, but having expecting anxiety or near within 10 to 15 minutes. Say example, before going examination or going to talk on a stage perform. So that time there'll be anxious, bro, next time I want to talk on stage. So what if I'm having anxiety attack? So that time, so bitter book are very good for the, so like social anxiety or stage performing. Stage performing anxiety, okay. Buspirone is an anti-anxiety drug which doesn't have any difference potential. It is a partial 5-HT 1 year is a pass by reducing 5%. So Buspirone also has a good management in anxiety disorder. Okay. Then phobia. Okay. Phobia is the third topic. Phobia is irrational fear of a specific subject or a situation or a activity, often leading to persistent avoidance of the feared subject, situation, or activity. So, example that will be a irrational fear. That fear is not a normal fear. Like say example, if you're seeing a cockroach, okay, there's a cockroach. Okay, we have to step aside. But on seeing a cockroach, the patient develop so much severe fear, and they'll be having, they won't go that side at all. Or they'll be seeing a cockroach very far. Then the fear that is, we can't able to explain the fear that is irrational to the situation or object or activity. So they'll be always persistently they'll be avoiding the situation, that area or that object or activity. Um, there are types of phobias or agoraphobia, social phobia, and some simple or specific phobia. Okay, so coming to like the various points in phobia is presence of the fear of an object. There should be a the object should be there, or situation or activity should be there for development of phobia. Fear is out of proportional dangerousness perceived. Say example, a cockroach won't kill you, but the fear will be like you're going to die. That is a fear. The fear is out of proportion to the danger. Say simple, fear is indirectly proportional to the dangerousness. Okay, the patient is unable to control the fear and is very distressed by it. They can't able to control the fear. So they'll be trying, and they end up in um, a low mood, or I won't be able to control this fear, what I can do. Like they'll be having that fear, that distress. Okay. Then this is the persistence avoidance of the particular object, situation, or activity. Then gradually the phobia and the phobic object become a preoccupation of the patient. So later on, once a phobia develops, later it will become a preoccupation of the patient. They keep on resulting in the marked distress, the restriction of freedom of mobility, and afraid to encounter phobic object or phobic avoidance. Okay. Agoraphobia is an irrational fear of situations. Commonest type of phobia include, okay, fear of being in a place away from familiar setting of home. Earlier, it was thought to a fear of open space only, but now they have revised that it includes fear of open spaces, public spaces, crowd places, or any other place where there is no easy escape to a safer place. Say, example, we're going into a crowd, suddenly you develop a panic, phobic attack. So that time you are in the middle of the crowd or in some obese crowd, suddenly you can't escape from the crowd. So if the difficulty, um, there's no easy way to escape. Anyway, if you rush, you can try to escape from the place. There are immediate escape from that place. So those sorts of places called as agoraphobia. That is public places, open spaces, crowded, or say those places. Okay.